Welcome everybody to Go Local Live. I'm Josh Fenton, CEO and co-founder. A little news before we go to Dr. Fine. First up, issues related to the federal stimulus are starting to boil over. There's a story today in Go Local about how restaurateurs are having a very tough time not only tapping those federal stimulus dollars, but also what the implications are for them tapping them. Secondly, later this morning at 10 o'clock, Governor Raimondo, Senator Jack Reed, and Congressman David Cicilline, along with Commerce Secretary Stephen Pryor, had a press phone call introducing that Goldman Sachs has agreed to step forward with $10 million to backstop some of the stimulus loan programs. These are the dollars to go out and give 2 months of relief to small businesses to be able to keep their employees in place. Those loans may in fact become forgivable. There's lots of complexities with it. Big banks around the country gobbled those dollars up early. Those dollars are running out across the country. This assistance by Goldman Sachs should help at least a small portion of those who need. Rhode Island has about 30 to 40,000 small businesses. If you do the math, you'll figure out that even $10 million is not going to go very far in the amount of demand that people need to run their businesses for 2 months with virtually no income coming in. So a little good news, but does not answer the huge missing gap of the amount of financing needed. 1 o'clock today, we'll have Governor Raimondo's briefing. Again, her press office and she continue to block the public from hearing press phone reporters' questions and their follow-up questions. That's still barred accordingly. Let's go to Dr. Michael Fine. Dr. Fine, how are you Monday?
I'm good. Good afternoon. Nice to see you.
Great to see you, sir. Let's go through the numbers. There was lots of little milestones, all bad this weekend. Maybe the only good milestone was New York may have plateaued. We don't know for sure, but let's go through the numbers.
Sure. And remember, 1 or 2 days is only 1 or 2 days. You need a week or two to really see a trend. The best number, of course, is that 435,000 people around the world have recovered from this disease. There are 1.875 million people who are tested cases, up about 70,000 from the day before. 561,000 Americans tested cases, up about 25,000. Unfortunately, 116,000 deaths around the world, increasing about 6,000 a day. In the United States, we're at 22,161 deaths, increasing over the weekend about 1,500 people. I'm always cautious of weekend numbers because I'm not sure the reporting is always that accurate. In Rhode Island, 4 new deaths over the past 24 hours. Up till yesterday's reporting, 316 new positives, 201 people in the hospital, 15 people in the ICU, and 60 total deaths. The really good Rhode Island news is that the rate of growth in ICU numbers and hospital numbers, though they're growing every day, is still not so intense as to make this undoable. We are still doubling more than, it takes us more than 5 days to double, which is really, really, really good news for us. It will give us more time to prepare and suggest that the real surge is still probably 2 to 3 or even 4 weeks away.
Dr. Fine, you've said that the key numbers to watch are hospitalizations as well as ICUs. Those numbers that you repeated are good news. No two ways about it. That's going to give us A, more time, and B, hopefully keep the number of folks in Rhode Island who pass away from this on the lower tier that we can possibly hope for.
That is what we are hoping to achieve, at least in the short run. I'm still looking for some data on the ICU numbers, the hospital numbers, and the deaths by locality, by race, by income to give us a little bit more understanding, not just of who's infected, but who's getting sick and dying. Because at the end of the day, our job isn't to control cases, because remember, we're all getting this disease. We're not going to. Our case number is probably going to be upwards of 600,000 or 700,000 if we really had a measure of it. Our real objective needs to be to reduce the number of people who are hospitalized and unfortunately die. And we got to understand who's at greatest risk for dying and how to mitigate those risks.
Listen, we have an editorial today on GoLocal calling out the state for the lack of demographic information, and other states are not only producing that data, they're leveraging that data in order to make sure that the resources are dedicated to the right folks who have the highest risk and are most in need. It's also my understanding that the NAACP Providence chapter has come out with a really strong language calling for the state to get forward with it. I don't understand how this data couldn't get collected from day one. You know, it's a medical record, correct? It's a piece of data, check the boxes, race, age, gender, address. It's not much more complicated than that.
Well, it is around income for sure, because we don't generally ask for that information. And so I suspect people are going to make assumptions based on the zip code or even the census tract in which people live. The income data is quite tricky, and race is not consistently collected in a coherent way at the time a patient presents. You know, then you've got the whole process of the Twin Rivers, the whole Twin Rivers process, and I don't know exactly what's being collected there or how precisely that's being dealt with.
Well, I think, though, that demonstrate the lack of sensitivity to the need for this information? Wouldn't you, on day one, as any demographer would do in healthcare, identify that those that are critical to be able to identify? I'll also push back a little bit. Maybe zip codes give you a false positive. Census tracts are much truer. Yes, there's some complexity of census tracts in places like downtown Providence, where high income rental and condo units are in the same census tract as lower income folks in the South Side. But other than those exceptions, census tracts at least gives you some directional information, and obviously race gives you some directional information. But just age and gender doesn't give you much at all.
Right. I think we agree on that. But as I said, since income information is not generally collected, right, somebody's gotta massage the data to turn address into some construction around income in order to get a sense of who's being affected. And even that, you know, as you said, because there's mixed housing, even that's a rough approximation.
The numbers do show that both Rhode Island and Massachusetts, I believe, are in the top 10 for deaths per 1 million in population. Massachusetts is actually higher ranked. Rhode Island, I think, is 9th. Number of cases, as we've discussed numerous times, is as much of a function of testing, which Rhode Island now, over the last week or so, has gotten its testing program functioning. Although today, just as a side note, testing is suspended because of high wind warnings at all the outdoor facilities. Talk a little bit about, if we're 4 weeks off and we're already 9th in deaths per 1 million population, what the next few weeks look like.
Well, you know, deaths really reflect more than anything else the what's called the immunocompetence of the host. That is the extent to which someone is able to fight the disease at baseline. We know Rhode Island has lots of older people and lots of the people called the old, people over 85. They are at great risk from this disease. As this disease finds its way to them and finds its way to more nursing homes, I expect to see our numbers continue to rise. Unfortunately, I think that's a major predictor. And again, race and income are a predictor, not specifically in terms of, causing a death, but race and income gets at the extent to which we as a nation have allowed a segment of our population to be beaten up physiologically over time. And so it's those people who are at most risk of death. And that's why paying attention to those communities, getting to those people early when they're sick, and getting them to the hospital or into isolation when they're sick is really critical. And I think that's what the state's beginning to focus on. And I'm anxious to see them focus on that intensely and really without stopping, and really be effective at it, not just check a box, but really be effective at making sure every community can get tested, but even more, making sure that we have outreach into every community so that everyone who's sick and needs medical help can really pick up the phone and get it, and know when they can stay home or when they have to come to the hospital.
Dr. Fine, Spain announced, I think it's been a little over-reported, but Spain has announced certain types of jobs as they've seen what they claim is a plateau, and certainly not a week or more of plateau, but a few days of plateau, that folks can return to places like manufacturing to work. In Rhode Island, we never closed manufacturing, so not a major step, but in Spain, it's seen as maybe the light at the end of the tunnel. What's the danger of incrementally bringing back aspects of the workforce during this period of time?
Well, obviously the danger is the more people are out working and the more exposed to each other, the more the disease can be transmitted. Remember, I have big worries, and this is not evidence-based, but I have big worries about the extent to which people get more what I might call viral load, how much virus they get into their bodies at one time. And I think in a workplace, if people are not masked, that seems like a fairly substantial risk. I would love to see that any workplace really carefully screens for symptoms, so that anybody who's sick at all gets pulled out. But the risk is the more we do until we get to 70% of the population immune, the more we do, the more outbreaks we're going to see.
I've been to one grocery store in the past 10 days, a week ago today. I've driven by a number of construction sites. Regularly, I see folks not wearing masks, even after the order. Again, is this not enough education, not enough getting the word out, or not enough enforcement?
Probably a little bit of all. It's a hassle to wear a mask, but you and I are both doing it. My guess is for working people, it's enforcement, it's making sure the masks are provided to them, and it's kind of understanding that it's going to take some support and some encouragement, and on the part of employers, the ability to create some flexibility when someone's having trouble using a mask to do their job.
Let's wrap up. You've talked about the good news numbers. The good news numbers are the rate of growth for ICUs and hospitalizations are in a controlled growth pattern, not seeing hyper growth, more than a 5-day doubling cycle. What's the danger numbers you're seeing?
Well, I'm not seeing danger numbers, but it's what I'm hearing from communities. I'm worried that based on the 3 to 4 week lag between the time that people got infected and they're showing up in the hospital in the ICU, I'm worried that 3 or 4 weeks ago is when we really got intense about social distancing, and when we got people out of their communities, but very much into their houses, so that that's the moment when densely populated houses likely had lots of people living close together. So I'm worried that in the next week or two, we may see a bump from those people who have infected each other in households. Time will tell, but that's what I'm keeping my eyes on most closely.
Do we have a sense from the science? I know we talked about it early on 3-4 weeks ago, but is there any more data about from the date of exposure, how long it takes for the symptoms to manifest?
Well, remember the classic incubation period is 5 to 6 days, but people are reporting up to 14 or even 21 days. So that's the beginning of symptoms manifest. Then in the literature, people are saying that somewhere between 5 and 9 days is when what used to be called the crisis happens. When if you're going to get really sick, that's when you get really sick. So we're talking about a pretty big range of between 14 to 25 or 26 days from exposure to needing the hospital and needing it intensely. You know, the Germans apparently have what might be called flying squads that go around to the house of anybody who's isolating at home and tries to visit them, I think, on the 5th day and draws some blood. And I still haven't been able to find out what blood tests they're using, but they use some standardized method of determining who's likely to get into trouble, and they move those people into the hospital then. Might be something we ought to be thinking about and perhaps doing, particularly in our most high-risk, densely populated communities.
Dr. Michael Fine, thank you as always. Programming note, 1 o'clock, the governor's briefing, and we'll have that live. Again, that office is still not allowing reporters to directly ask questions and follow-up questions of the governor so that the public can hear it. Very different policy than Governor Cuomo or most of any of the other governors in the country, or even the White House. Thanks everybody for tuning in. Stay tuned for the governor at 1 o'clock.